Hello everyone and welcome back to our module on GIT pathology. So today we are going to speak about the topic Barrett's esophagus. Okay, so earlier we did mention about Barrett's esophagus once or twice. So try to remember in earlier video when did we speak which pathologies led to the complication of the Barrett's esophagus. You might like to think. Okay, so it was GERD and scleroderma in which this motility occurred leading to Barrett's esophagus. So here and here. So Barrett's esophagus. Okay, so now we will go in depth of what is Barrett's esophagus. So we know the normal esophagus is non-keratinized squamous epithelium, right? Normal esophagus is non-keratinized squamous epithelium. We'll come to this. Just wait. Okay. So in Barrett's esophagus, there is a specialized intestinal metaplasia, leading to the replacement of non-keratinized squamous epithelium with intestinal epithelium mucosa, which is non-ciliated. Intestinal epithelium is non-ciliated and columnar and with goblet cells. So normally goblet cells are absent in esophagus, but when there is a metaplasia taking place, it becomes non-ciliated, columnar with goblet cells. Okay, so and this occurs in distal esophagus. Okay, so and why does this happen? It occurs due to chronic GERD. Okay, so when there is more time, like so many times the reflux of the secretions is happening from the stomach to the esophagus, there is a metaplasia which is taking place. Malignant proliferation of glands via metaplasia. It is associated with increased risk of esophageal adenocarcinoma. You see, this is esophagus, this is the lower esophageal sphincter. At this point, there is normally it's a squamocolumnar epithelial junction, SCJ or Z line. It's also known as Z line. From this point is where esophagus meets the stomach. Hence, the epithelium converts into the columnar epithelium, which is seen in the stomach. Normally, columnar epithelium, where do we see it? We see this in stomach. But when there is a metaplasia taking place, the gastric acid is going again and again into the esophagus. The epithelium, which is in the stomach, is now seen in the squamocolumnar epithelial junction. Okay. This point moves upwards like this. Normally the squamocolumnar is this much, right? But now since the metaplasia is taking place, this grows. Squamocolumnar junction, Z line, grows and goes into the esophagus. All right. So and it will convert into intestinal mucosa. Metaplasia can further progress into dysplasia to adenocarcinoma. Normal squamous epithelium is white when seen, and intestinal is pink or red. Endoscopy is often performed in GERD patients. If Barrett is seen, there will be a regular surveillance endoscopy, and biopsies are taken just to look for carcinoma. Just to see Barrett, we can do endoscopy, but if you want to look for carcinoma, you do biopsy. All right. One thing you would like to note is that in Barrett's esophagus, there is an intestinal mucosa. Right. This is an intestinal mucosa. It is not gastric mucosa. No, not gastric mucosa. Gastric mucosa is the one which is in the stomach. So here it does convert to the columnar epithelium which is seen in the stomach. But you need to remember that in gastric mucosa, it is not gastric mucosa, because gastric mucosa does not contain goblet cells. And in this goblet cell is present, which means it is intestinal mucosa. You need to know this, that goblet cells are absent in the stomach. So the lining will be of the intestinal mucosa. All right. But this point, this will shift up. The squamocolumnar epithelial junction will shift up. All right. So now we will speak about esophageal cancer. So esophageal cancer is of two types: squamous cell carcinoma and adenocarcinoma. It typically presents with progressive dysphagia, like first to solids and then to liquids. All right, like initially the dysphagia was small, it is only to solid, but then it even exceeded and it increased to liquid, due to which there can be inflammation as there is the accumulation of the food. So there can be inflammation further proceeding to the cancer. So and typically presents with and weight loss, because obviously the food is not going into your stomach and is not being absorbed by your body, so it will lead to weight loss. And it will also lead to hematemesis, vomiting of the blood, aggressive course due to lack of serosa in esophageal wall, allowing rapid extension. Poor prognosis due to advanced disease at presentation. Usually it presents late with advanced disease, like it has already been mets into the lymph nodes. It is not seen early, it is not detected early, so it has a poor prognosis. Okay, let's try to understand why there is an aggressive cause due to lack of serosa, and why there is a rapid extension, and why is there a poor prognosis. Okay, so the esophagus lacks a serosal wall, which is the outermost protective layer of connective tissue found in most parts of the GIT, like stomach and intestines. They have serosa, but esophagus have a layer called adventitia, which is less effective at containing the spread of cancer. So what happens is there is an increase in tumor speed. Why? The serosa acts as a barrier that can help prevent the spread of cancer beyond the organ it surrounds. So without this layer, the esophagus is more vulnerable to the tumor cells infiltrating the adjacent tissues and structures early in disease progression. So because the esophagus is surrounded by loose connective tissue rather than a contained serosal layer, cancer cells can quickly invade the nearby areas, including the trachea, aorta, lungs, and mediastinum. Now, next, early lymphatic involvement. Esophagus has an extensive network of lymphatic vessels that lie close to the inner mucosal layer and submucosal layers. So, since cancer in esophagus can reach these layers early, it can spread rapidly through these lymphatic channels and eventually distant organs. So, the lack of serosal layer allows for easier lymphatic spread. You're getting my point, because esophagus has an extensive, first point is esophagus has an extensive network of lymphatic vessels, and cancer in the esophagus can reach these layers early. Why? Because there is an absence of the serosal layer. Now next, why is the poor prognosis? Because there is a difficult early detection. And why is this? Because the esophagus has minimal sensory nerves, so the tumors can grow without causing any symptoms, like there is no pain, until they obstruct the esophagus. So you will see the symptoms when the esophagus is obstructed. You cannot pass the food. There is dysphagia of the solids and then liquids progressively. So you will notice the symptoms then and there. Symptoms are until they obstruct the esophagus or invade the nearby structures. This often delays the diagnosis, meaning the time the esophageal cancer is detected is often in the advanced stage and has already spread locally or distantly. Okay, now coming to the types of esophageal cancer. So the first one is squamous cell carcinoma. It occurs in the upper 2/3 part of the esophagus. Risk factors includes alcohol, hot liquids, caustic strictures, smoking, achalasia. Okay. Upper 2/3 has alcohol. Like you see the food basically which you're taking from the top, like you're taking alcohol, you're taking like if you're drinking some hot liquid, you are caustic strictures like lye ingestion. Smoking is there in both, or achalasia. There is the absence of the movement, like absence of relaxation of the lower esophageal sphincter, increased LES tone. So basically the food is not going down. So basically in a squamous cell carcinoma upper 2/3, the food is coming from the up, anything, alcohol, hot liquids, caustic strictures, achalasia. So the risk factors are these. And it usually occurs in the middle or upper esophagus, upper 2/3. Then comes adenocarcinoma. Adenocarcinoma, it occurs in lower 1/3, so it is from down. So chronic GERD, like the acid is coming up from down, like from down into the esophagus. Barrett's esophagus. We heard like it's a complication of the GERD. It occurs metaplasia of the non-keratinized stratified squamous epithelium into intestinal epithelium, non-ciliated columnar with goblet cells. Okay. Obesity basically the fat down is pushing up. Okay, the fat layer down. Tobacco smoking, and it's more common in America. The trick is A here. Squamous cell carcinoma is more common worldwide. Okay. Now we'll speak something more about squamous cell carcinoma. Anything that obstructs the passage of food and liquid through esophagus can lead to the damage of the upper esophagus from back of food, like achalasia, esophageal webs, Zenker diverticulum. All these can lead to squamous cell carcinoma. Since we spoke about Zenker diverticulum, I would like to speak something more about Zenker diverticulum. Zenker diverticulum is a pharyngoesophageal false diverticulum. It is a false diverticulum. We will later on know what is true diverticulum and what is false diverticulum. Right now, we just need to know that Zenker diverticulum is a false diverticulum. Esophageal dysmotility causes herniation of the mucosal tissue at area of weakness between thyropharyngeal and cricopharyngeal parts. Area of weakness between thyropharyngeal and cricopharyngeal part. So there is an area of weakness. This is the Killian's triangle. Okay. So esophageal motility causes herniation of the mucosal. The mucosal tissue herniates at an area of weakness between the thyropharyngeal muscle and cricopharyngeal muscle. Parts of the inferior pharyngeal constrictor. This is known as Killian's triangle. It is located in the hypopharynx, just proximal to or above the upper esophageal sphincter. Junction of the esophagus and pharynx. It is junction of esophagus, which is known as pharyngoesophageal false diverticulum. The symptoms will be dysphagia, obstructing, gurgling, aspiration, foul breath, halitosis, because food is trapped in the diverticulum. Neck mass. And it is more common in older adults. It is usually result of a chronic swallowing problem. Cricopharyngeal muscle relax to allow the food to pass, and if there is a failure to relax, it can lead to difficult swallowing. Chronic high pressure in the pharynx to force food down can lead to diverticulum. So basically, cricopharyngeal muscle here, it must relax so food can come down. But if there is a failure to relax due to any reason, there will be difficult swallowing, but there is a chronic high pressure in the pharynx. In the pharynx, there is a chronic high pressure which forces the food down, and but the cricopharyngeal muscle is not able to relax, so there will be a area of weakness formed, and there will be herniation of mucosal tissue, and it will lead to a diverticulum through Killian's triangle. So this is an acquired defect in the muscular wall. It is not already there. It is an acquired defect because of the pressure, and cricopharyngeal muscle is not able to relax, so the mucosal tissue herniates. Okay. It can cause special symptoms due to upper location, such as hoarseness of voice, because the recurrent laryngeal nerve can be involved in the upper esophagus. It can also lead to cough due to tracheal involvement. Squamous cell carcinoma is characterized by flattened polyhedral or ovoid epithelial cells with eosinophilic cytoplasm, keratin nest or pulse within or between the cells, and intercellular binding. Esophageal SCC typically presents with progressive solid food dysphagia and weight loss. A more significant risk factor in US, including cigarette smoking and alcohol intake. In Asia, chewing of betel nuts and consumption of foods containing N-nitroso compounds, often found in preserved or pickled vegetables, are commonly associated with SCC. Okay. Now we'll talk about the metastasis. So lymph nodes, metastasis to the lymph nodes. Now we have to know what are the lymph nodes and it is situated where. So in upper esophagus or neck, there is a cervical node. So it can metastasize from upper esophagus, it can metastasize to the cervical node. In the middle of the chest part, there are mediastinal nodes and tracheobronchial nodes. In the lower abdomen, there are celiac nodes and gastric nodes. You need to remember these nodes. Cervical nodes in the upper part, cervical. Yeah, you know, cervix is the upper part. Middle chest part, in mediastinum. Mediastinum, as we said before, it is the space between the lungs. And tracheobronchial nodes, like the bronchus and the trachea, are in the lungs area. So, the tracheobronchial nodes, the celiac nodes and the gastric nodes are down. Gastric nodes, you can understand, the gastric part is the down, and celiac nodes. One reason for this aggressiveness is that the esophageal wall, we already discussed this, right? Now here is a point. Aspirin and other NSAIDs may be protective against esophageal cancer, especially in the setting of Barrett's esophagus. These feeds are also protective against colorectal cancers, and aspirin and SIDs are protective against esophageal cancer in the setting of Barrett esophagus and colorectal cancer. Barrett's esophagus was the adenocarcinoma because it was coming from down to up, right? Now